Hello. So now we are going to see about Helicobacter pylori. Helicobacter pylori is a gram-negative seagull-shaped bacillus, and it has a prevalence of around 80% in developing countries and lower in the developed nation, that is around 20 to 40%. It generally has a good prognosis with eradication therapy, but untreated infections can cause complications. So let's see about Helicobacter pylori. So over here I have the pathogenesis. So what happens is the bacteria will come, it will cross the gastric fluid, it will come into the mucus layer and it will get embedded in the epithelial cells. Once it gets embedded in the epithelial cell, it will neutralize the acid by help of urease enzyme. There is urea present. This urea will be broken down into ammonia, which will increase the pH, that is, make it alkaline. And the alkaline acid will react to form a neutralization zone. In this neutralized zone, bacteria will rapidly multiply and it will increase in numbers. Once the bacterial load is increased sufficiently, the bacterial mucinase and various other pathological changes will be induced, which will be leading to inflammation, which will be by gastric acid, proteases, and other things. So over here we can see once the bacterial load increases, it will cause the ulcer by removing the protective layer. We have a eosinophilic protective layer, which is of mucin and bicarbonate layers, bicarbonate ions. So induction of pathological changes. So these are mainly by three, four mechanisms. They are by cytotoxins, genes, and molecular mimicry. So I have vacuolating cytotoxin A or VAC-A. This is secreted by the H. pylori, which will induce and formation of vacuoles in the cytoplasmic epithelial cells. And then this have the cytotoxic associated gene cell. This will cause cytoskeletal rearrangement, host cell morphological changes, and expression of the proto-oncogenes will be caused by this, and it will cause pro-inflammatory cytokine release. I have molecular mimicry. A point to note in the molecular mimicry is it will cause mimicry similar to those of lipopolysaccharides or glycoprotein moiety of the lipopolysaccharides, which is very similar to the Lewis blood group antigen present on the human cell. So as they're having similar reactions, so immune tolerance will be developed against T cells by down regulating the T cells, and induction of autoantibodies will be there that will cross react with the mucosal epitopes and which may cause chronic gastritis. Then I have alteration in gastric mucus. This is due to as LPS will inhibit the glycosylation and sulfation of gastric mucus. Therefore, the protective function of will be reduced. So I have other environmental risk factors like smoking, diet, and other things. So talking about the spectrum of disease that can be caused by H. pylori, I have chronic gastritis, peptic ulcer disease, gastric adenocarcinoma. That is, it will actually increase the risk to get gastric carcinoma and gastric mild lymphoma. So adenocarcinoma and lymphoma both will be caused by H. pylori. So the virulence that of H. pylori, it is linked to three things. There's the flagella, urease, adhesins, and toxins. Toxins such as cytotoxin A, genes, which is covered earlier, and flagella. Flagella will allow the bacilli to move in the thick viscous mucus, and urease. Urease will generate the ammonia, which will cause neutralization in the acid, and therefore it is easier for it to attack. Then I have adhesins. Adhesins will help the surface to attach to the mucosal cell. I have blood group antigen binding and adhesin. This will bind to the Lewis blood group antigen and it will cross T cell tolerance. So talking about lab diagnosis of H. pylori, I can have invasive and non-invasive mechanisms. Talking about invasive diagnosis, it is mostly based on biopsy or endoscopy. Talking about endoscopy based diagnosis, I have Antrum endoscopy is the mostly preferred endoscopy. I have histopathology, and histology is done with Wharton's tarry silver stain, which gives a very nice appearance of H. pylori. In microbiologically, I can have gram staining and culture. It can be done on cirrhosis chocolate agar, and identification can be done by Maltitov Vitek bacteria. That is the automatic detection method. I have another ureases that is called rapid urease test. This is done in the biopsy. So what happens? It detects the presence of urease activity in biopsy by using a broth that contains urea and a pH indicator. It is rapid, it is sensitive, and it is cheap. So it is a good thing. So over here you can see a gram staining picture of H. pylori. The shape over here, the bacilli, it appears like a seagull with wings. So I will show an image of seagull. You can see this wing of the seagull. The shape is something like this. And you can see the shape over here. Or see the shape. See this bacilli. See this bacilli. So this is a cultured bacilli of cultured H. pylori, from which we have taken and done a gram stain, and we have got this. So next, talking about the non-invasive diagnosis, these are the preferred tests. So I have urea breath test. What happens? As there is H. pylori in the intestine, it will cause the urease activity to be increased. Due to this urease activities, I can just ask the patient similar to a breath analyzer. So patient will blow and we can see if it is there or not. So what happens is I will make sure the patient drinks a solution of urea with a non-radioactive, that is C13. Once just for 5 minutes, I'll ask the patient to blow. If urea is produced by H. pylori is present, the urea is hydrolyzed and C13 labeled CO2 is present in the breath samples. Next is corpoantigen or fecal antigen assay. Over here, it is highly sensitive and specific. It detects both live and dead bacteria, but the only thing is it can't distinguish whether a previous infection or present infection. I have serum IgA. It is pre-endoscopy screening and for epidemiological studies. Next, talking about the gross features, the antrum is the preferred biopsy site for evaluating H. pylori. Gastric biopsy specimens generally demonstrate H. pylori in infected individuals. Organism is concentrated with superficial mucus overlying the epithelial cell. Distribution can be irregular, some with heavy areas of colonization, some with few areas of colonization, which will give a very patchy appearance grossly. So over here, I have an endoscopy image. I can see the ulcer over here. In this ulcerative area, I can see the H. pylori present in the biopsy image, H&E stain image below. This is the raised biopsy of area. Next, I should be covering the Wharton starry silver stain. Over here, I can see the Wharton starry silver stain. Over here, due to silver, I can see the bacilli is very nicely highlighted. See, this is the bacilli. Bacilli are very well highlighted over here using Wharton starry silver stain. This is done for identification purpose. Next, H&E stain. So next I have an H&E stain. Over this is H&E stain of the mucus of this over here. I can see the epithelium, and below the epithelium I'm able to see increased amount of plasma cells. These are the plasma cells that are having, and I can see inflammatory cells. See, this is a plasma cell over here. Let me change the color of the pen. See, this is a plasma cell over here. So lot of inflammatory mediator cells are seen over here. Next, I have the section of the entire mucosa. So I will just zoom in. So over here, I can see lymphoid aggregates with germinal center. So this is the germinal center, and lymphoid aggregates can be seen in germinal center, and abundant subepithelial plasma cells with superficial lamina propria. So over here, I have the epithelium and lamina propria over here. In the lamina propria, I am able to see a large amount of plasma cells, and over here, lymphoid aggregates I can see. So what happens is neutrophils will infiltrate across the basement membrane and accumulate in the lumen of gastric gland or pit to create pit abscess. Lymphoid aggregates, some with germinal centers, are frequently present and represent malt tissue. That is, they are not malt tissue, they are induced malt tissue, the one over here, these. So this has a potential to transform into lymphoma. Thus, I can say that H. pylori gastritis is associated with a greater predisposition of both adenocarcinoma of the stomach as well as lymphoma. So I will just zoom in here. So over here, I am able to see the epithelium, and below the epithelium, I can see the lamina propria. In the lamina propria, I'm able to see the glands. Abundant glands are present over here, and I will just zoom out. And in this part, if I zoom, I can see the germinal center and lymphoid aggregates are seen. Germinal center is pale color with respect to this. This is a induced small tissue, and this may will dispose the patient to getting more complicated if not managed properly. Now I have the risk factors for peptic ulcer disease. There are H. pylori infection, cigarette use, then chronic COPD, some addicts like cocaine that reduce the mucosal blood flow, NSAIDs, then alcohol cirrhosis, physiological stress, endocrine cell hyperplasia, Zollinger relation syndrome, and viral infections such as CMV, herpes, and other viruses may be causing it. So next, over here I have the image of ulcer. So over here I can see this is the lumen. I have the infiltrate, that is the inflammatory infiltrate over here. I can see the base of the ulcer. This is the necrotic ulcer base. This is composed of granulation tissue. What are the clinical features of peptic ulcer disease? So clinical not of peptic ulcer diseases. So the clinical features are that peptic ulcers will present with epigastric pain or aching pain. That is 1 to 3 hours after the meals, which will worsen at night, somewhere around 11 p.m. to 2 p.m. to be more accurate. And they are relieved by food or antacids. That is, on drinking milk, it will be reduced. Some patients are present with complications such as iron deficiency anemia, hemorrhage, or perforations. Other symptoms can include nausea, vomiting, bloating, belching, and significant weight loss. Pain from penetrating ulcer can lead it to the back, upper left quadrant, or the chest. This may be mistaken for cardiac pain. Treatment focuses on eradicating H. pylori, that is by antibiotic, neutralizing the gastric acids by proton pump inhibitor or antacids, continuing NSAIDs or any COX-2 inhibitors because COX-2 is present in the stomach. COX-1 is present in the stomach, so this may cause a reaction. So we stop both all COX and COX-1, COX-2 inhibitors. And also we may give metoprolol, which is a prostaglandin analog, which helps in the maintenance. So what are the complications of peptic ulcer disease? The complications can include bleeding, which occurs in 15 to 20% of the patient, perforation and obstruction. In obstruction, what may happen if it is obstructed for a longer time, fibrosis may occur. We are not that interested in fibrosis because if fibrosis occurs in the intestines or the stomach, so it has to continuously do peristalsis. The muscle movement should be there. If fibrosis occurs, this movement will be hindered. If this movement is hindered, the digestion process will be hampered. So bleeding, perforation, and obstruction. These are three complications of peptic ulcer disease. Bleeding occurs in 15 to 20% of the patient. It is the most frequent complication. As the upper GI bleeding, it may present with melena, that is black tarry, coal tarry stool color appearance, and perforations in 5% of the patients, and it is rarely the first indication. So next, talking about the anti-H. pylori regimen, I have first line regimen, second line regimen, third line regimen, and these are the three regimens that I have. The first line regimen is by three antibiotics, and second line regimen is also by three antibiotics. The third, they are known as triple regimen, and the third line regimen is known as quadruple regimen. It has four drugs. So in the first line regimen, I have proton pump inhibitors, I have amoxicillin, I have clarithromycin or metronidazole. In the second line regimen, I will have PPI plus amoxicillin. I have to continue that, and clarithromycin or metronidazole, whichever was not used in the first line treatment. Suppose a patient has received both metronidazole and clarithromycin, then we will start with tetracycline and fluoroquinolone such as levofloxacin. And suppose a patient is allergic to penicillin, then what we have to do? In that case, I have to stop amoxicillin. I have to also go with clarithromycin or metronidazole. So talking about the dose, PPI I have like omeprazole, esomeprazole, pantoprazole. These can be given 20 mg BD. Lansoprazole. Over here I have the list of names. Amoxicillin, it is giving 1000 mg BD. Clarithromycin 500 mg BD. Metronidazole 500 mg BD. Tetracycline 500 mg BD. And talking about the quadruple regimen. So this is the third line regimen. What I do, I will keep the PPI, that is omeprazole say, and amoxicillin. Omeprazole BD, amoxicillin BD, 1000 mg and 20 mg. Along with this, I will give a ulceroprotective drug like CBS, colloidal bismuth or bismuth subcitrate. What will happen? This will go and protect the base of the ulcer, and it won't do further more damage, further more bleeding. This will be prevented. Other than this, I have clarithromycin, metronidazole, tetracycline. Any one of these drugs has to be continued. That is based on the EST or whichever has been not been given. I have to continue for 10 days. This is the regimen for the treatment of H. pylori. So I have first line regimen, that is PPI, amox, clarithromycin or metronidazole. Second line PPI, amox, clarithromycin, metronidazole, which is not used. Then if patient is allergic, I can replace metronidazole or clarithromycin will be there. I can replace amoxicillin with metronidazole clarithromycin, or if the patient is not responding well to clarithromycin, I can start levofloxacin and tetracycline. And third line adjuvant, PPI, amoxicillin, CBS, that is colloidal bismuth substrate, and clarithromycin, metronidazole, tetracycline, any one of the antibiotics. Antibiotics doses are shown in the screen, and proton pump inhibitor are given BD, that is 2 times a day. So thank you.